Hello, ladies and gentlemen. I am Dr. Yushen Li. I want to thank you all for attending this online workshop lecture. It is my great honor to introduce Professor Wenju Song. Professor Song graduated from National Defense Medical Center, Taiwan. Now he is the Associate Dean of China Medical University, Children's Hospital, Taiwan. Professor Song is an expert in pediatric diagnostic and interventional bronchoscopy, and he also invented many innovation skills. He is going to give us a special lecture entitled Pediatric Flexible Fiberoptic Bronchoscopy Cases Demonstration. Let's welcome Professor Wenju Song.
Ladies and gentlemen, it's my great honor and I'm very pleasure to invite by the APPS 2021. Just this part is a pediatric interventional flexible bronchoscopy. Here I will present 8 cases about the flexible bronchoscopy in pediatric. I'm Wenju Song. I live in Taiwan. Okay, this is first case. Case 1, a female newborn, the age 37 weeks. Prenatal diagnosis is ultrasound diagnosis, maybe one lung agenesis. So he transported from the other medical center to our hospital. In our hospital, he born by normal delivery, spontaneous delivery, and the birth weight is 2.7 kilogram. Upper score is 5 at 1 minute and 6. This picture is taken at the age of 30 minutes. You can see the lung is abnormal. The right lung almost total white out, and left lung have some not clear lung field. Okay, so after birth, this baby presents symptom sign. He had massive fluid come from the mouth and the nose, and the respiratory districts. You can see that's bone at a 10 age. Traction. Hurry, 150. You can see retraction from the tongue. So we do suction and oxygen. The congo. Question: how to make the diagnosis? The X-ray have taken. We do a scope. This is a scope. Flexible endoscope. From the nose, left nose, the nasal tract and the pharynx is clear. The structure of the larynx, epiglottis, seems okay. And the vocal cord open. The vocal motion is okay. These are trachea. Trachea lumen seems okay, but at the low trachea, it seems abnormal. They have 3 holes. One big hole, one big hole, one big hole, and 2 small holes. The big hole, the scope go into the big hole and show a structure look like a esophagus structure, and the scope pass over the junction and see a huge cavity, the mini stomach. So that huge picture means the esophagus going to the stomach. The trachea esophageal picture. And then we change to a small endoscopy. Going to the central is a pinch from the bright end. So we scope it. The same scope going to a small channel. This structure looks like a trachea. This is a distal branch. The lumen is narrow. So severe tracheal stenosis. And then we go back to the pharynx and endoscope going to the esophagus. The esophagus is a grand pouch, not a pattern. The depth of the pouch about 2 centimeters. So we use this esophageal gastric endoscopy to do the diagnosis. Okay. The scope diagnosis. After the scopy, we can draw a picture about this baby's anatomy. This is a brain pouch. This is a trachea. But in the lower trachea, we see a huge fissure. This fissure going to esophagus, going to the stomach. And the central is a small brain end pouch. Brain end. And in the other side is a small distal trachea, stenosis. The estimated the lumen about 2.5 millimeter. So his heart is shift to the right side. Shift to the right side. These are anatomic diagnosis. The fissure diameter about 5 millimeter. The esophageal atresia, 2 centimeter water depth, and the severe low trachea. So we use the endoscope diagnosis, anatomic diagnosis. In this case, after the diagnosis, we do a lot of treatment, teamwork, including tracheoplasty and the stent implantation. The fourth one is doing a gastrostomy, emergency gastrostomy, for decompression of the stomach. The second is do the end-to-end anastomosis of the esophagus. And the third is a stent implant, because the esophagus fissure always combined with tracheomalacia. In this case have also done the graft to tracheoplasty to a graft implant to make the lumen wider. But this graft causes tracheomalacia. So after this surgical procedure, we still tracheomalacia. So we put a stent inside, cover the malacia segment. After this treatment, the baby became stabilized, much stable, and then discharged. This is a second case, 1 month old infant, present with noisy breathing and poor feeding. Irritable. We take a picture with chest film, including neck, but cannot show the upper airway. What problem? Nobody knows. So because this symptom, so what study may be checked? Okay, this is we do a endoscope. You can see a mass-like lesion, almost complete block the subglottic region. Almost 100% block That's why he had dyspnea and the suicidal retraction. This is endoscopic diagnosis. Subglottal soft tissue mass, almost 100% human growth. Maybe hemangioma. In our experience, that's most likely the hemangioma. So we do a CT. This is a little soft tissue neck. You can see hyperinflation of the hypophysis, hyperinflation. That should be the distal side have some obstruction. This is a CT film show a density, a bright density just at the subglottal region, almost complete, block the lumen. How to manage this reserve status? Patient, the baby is dyspnea and cyanosis. Traditionally, if the hemangioma is diagnosis, subglottal hemangioma, highly suspect. Traditionally, the treatment for the hemangioma, the oral propranolol, 2 milligrams per kilo per day. But this case is very dyspnea and retraction. In oral interval, maybe response, but it's slow response, not in time. Cannot immediately resolve the dyspnea. How about nasopharyngeal CPAP? May not enough, may not effective because severe, almost complete block the lumen. The CPAP pressure may not be enough to penetrate the airway. How about tracheal intubate? Not effective and too suffer, too invasive, and just maintain his airway, but cannot resolve the mass. So how we do? We just do the laser ablation and with the oral propranolol. We show immediately after the endoscopic diagnosis, we immediately treat with a laser. This is a video. A laser fiber through the flexible endoscope inner channel to approach the mass. You can see the laser. Gradually operation. Rupture this way. Some fluid come out, some fluid come out, and the size, mass size decrease, gradually decrease. And women get some pattern. After this treatment, we give oral medicine, propranolol, and keep on nasopharyngeal CPAP. This patient never intubate. About 1 month later, we will check what happened of the lesion. 4 months later, you can see the lesion almost disappear, and this even being okay. The tracheal lumen is quite paper. It's okay. It's okay. In many top airway or subglottal tissue, we can use the laser plastic. or upgrade the redundant feature or the mask issue. Case 3, just 6 months old male infant, body weight 6.7. The past history is a T fissure with esophageal atresia after surgical correction, but still distant. Still distant. Can see and we do at the bedside, we do the bronchoscopy to check. You can see the trachea lumen almost complete collapse, almost complete collapse. That's why he clinically show severe dyspnea and air hunger. This is a carina. Carina side also collapse, especially in the left side, left side. Severe tracheal malaise. That's made very frequently after the T fissure correction. The trachea still a problem. Okay, after the endoscopic diagnosis, he had been visited several medical center, but nothing can do. But the patient still distant. So come to my hospital, we do this scope. And this is after this is a body weight. You can see from 6.7, around 6.7, no body weight yet, 6 months old. What do we do? We put a stent, like the first ball from those stent. Just stent. Magnetic stent, balloon expandable. We check the distal end of the stent at the carina level, and we check the proximal end of the stent at the proximal side of the muscle. The other stent should cover whole segment of the muscle. We check again, double check the by end of the stent. After we confirm the location, we just inflate the balloon. To expand the stent, and then several seconds later, we deflate the balloon. And this is a final check. We can see the magnetic stent location is a distal trachea, and the tracheal lumen is very patterned. So this infant never intubated again, and just in the OPD follow-up about every 3 to 6 months follow-up. This picture have and also look at body weight gain from 6. That means it's is good for the just this kind of patient. Case 4. A 1.5 months old infant and dyspnea since birth. He failed to medical management, including medication or misoprostol, and failed to expert. You can see just demo for the stent implantation. This case also have severe trichomoniasis, very long segment. He also transport from the other medical center. Long segment trichomoniasis is a congenital. She had no congenital heart disease. She had no congenital heart disease. We put a stent. The technique, all under the non-invasive radiation support without any airway instrument. You can see inflate the balloon to expand the stent. Then deflate the balloon. And the stent is good, okay location, and we can see the distal arena is paper. So this patient discharged just like this picture. There's no any artificial airway, no mask, no endotracheal tube. Just an oxygen test. This is a flexible endoscope going to the trachea. This is a stent deliver test also in the trachea. So in trachea, have two instruments. One is a stent tester, the other is an endoscope, just like this picture. The stent should be regular follow-up because stent may be damaged, maybe destruction. So in this case, we regular follow. And this video show two tester, two balloon tester, and one endoscope. And so this demo for the stent implantation and how we repair a damaged stent. Just like this, in the trachea, they have three instruments, two different color balloon tester and one endoscope. There's no any artificial airway inside. This picture shows the step by step for how we implant the stent by flexible endoscope. Just a tracheostomy. This is with insertion of the balloon tester. This confirm make sure the location of the stent will be implanted the location. This inflate the stent, expand inflate the balloon and expand the stent. Just deflate balloon and the stent cover, coating in the lumen. You can see after stent implant, the lumen becomes much better. So the stent is very effective for, especially for the trichomoniasis. Case 5. Case 5 also an infant after the EA and the T fissure repair, but still chronic choking and recurrent pneumonia. How we to differential or to make diagnosis of a residual feature, because this symptom sign may be suspect of any residual feature. This we demo how we use the methylene blue test. You can see prepare a methylene dye in a syringe and with a soft test. And we see put the test. Test. During procedure, the vital signs. The middle esophagus. Make sure that the test esophagus have the fixed test. Make sure the test in the esophagus. And endoscope, we see. Endoscope, you can see. This is a esophageal test. Ask the assistant. Slowly push. Have a watch. Slowly. So gradually going to the esophagus, and we change the side. We do the diagnostic machine test. Okay, this is a test, the esophageal test. Endoscope inspection of the whole procedure. You can see the methylene blue dye going to the esophagus, and the endoscope going to the trachea. And the weight of this still magnesium, but we use the INV to inflate the lumen. To inflate the lumen, and we look for any dye leakage. That's okay. Still okay. Oh, you can see the blue dye come out from the fissure. That means this fissure is a residual steel fissure. So material fluid can come from the esophagus, go into the trachea lumen. That means the fissure still exists even after surgical correction. So we use this endoscopic technique, methylene blue dye test. We can confirm or make diagnosis. This is a clinical application procedure. Prepare a syringe, grow with methylene blue dye, and connect to a small tester. So, sorry about this. And insertion of the tester to the middle esophageal lumen, and in the bronchoscope in balance to check the slowly push methylene dye, and endoscope inspection the treatment. It is used for diagnosis for residual P fissure. For some stent cover P fissure, but still leakage. We also can use this technique, and also H-type feature, because usually H-type feature is tiny, is very small. We can use this test to make diagnosis. Case 6. This case, a 10-year-old boy had accident, aspirated a pencil cap for 10 days ago. He immediately had similar sign of dyspnea, retraction, and fever. So in the outside hospital, the surgical team tried radioscope for 2 times, try to remove the foreign body, but failed. And also because it's very difficult to remove, the forceps, rigid forceps, semi-rigid forceps tip fracture. You can see from the picture, from the X-ray. This right lower lung is heaviness, collapse, and there is a density. You see, a wide metallic density in the right lower lung. This density is a fracture forceps tip, which overview. This is a pencil cap. It look like this, the size about this. So he come to my hospital, and we check the chest everything, and then chest CT thing. You can see in the right lower lung half broke, lumen broke, lumen broke. Also show a density, this density in this side. This density in this side, maybe the other foreign body of the fracture forceps. Look like this here. So we do the flexible bronchoscope. The scope check through the trachea. In the membrane portion, we have seen the membrane portion tissue damage. Why damage? Because the radioscope damaged the mucosa. And the right side, the secretion is thick secretion pooling. We use a suction. This suction is just side by side, alongside of the endoscope. After suction out, we can see a foreign body inside. Totally impact the lumen. That's why the right lower lung collapse. So after make diagnosis, the foreign body aspiration, like this, how to manage this patient. The radioscope is failed for 2 times. How we do this operation? Explore, not just to suffer. We just in the pre-endoscope management, before we try to remove the foreign body, we in the outside in vitro, we take a test. We use a ear hair hole, small hole, 1.5 millimeter hole. This hole can bypass by a 3 millimeter balloon test. So we put the balloon tester through the hole and inflate the balloon. By this way, by pull out the tester, we can drop out this foreign body. So we do this way in the treatment. We use a guide and followed by a balloon test. And another scope. We gradually pull back, pull back, pull back, pull back. Very strong pull back. You can see more. Finally, we move out this. And after more, we will check the lumen. This is a right low branch. The foreign body has been moved. They have some necrosis exudated distal as a distal lumen, but we cannot find the fracture forceps. Okay. This is a procedure. Here we do a balloon caster and an endoscope, just side by side. There is no any mask, no endoscopy. Just like this. In the tracheal bronchus lumen, this foreign body, this is a balloon caster. Inflate balloon and under the endoscope inspection, we gradually pull out the foreign body. This kind of case, we have the total we collect 4 cases and published in 2015. You can see this case after take out the foreign body. This is a balloon caster. Through the nose for trachea, and we pull out, and the foreign body come out from the trachea at the balance, and we use the forceps, the alligator from the mouth. We take out the foreign body, just like this. And this case is for give the pharyngeal oxygen test. And endoscope from the nose going to the trachea, just like this. Okay, this is a picture before we move the lung collapse, the low lung. There's a density of the foreign body. The pressure was a fit, just like this. And this just remove, we can see they have a gradually resolution of the density because some secretion come more. Just 3 days after foreign body removed, almost total clear the collapse lung, and then the foreign body is still there. This case those fall out, never come back. But 10 years later, he come back again, and we take the chest rate, and this foreign body never see. Nobody know when he come out, maybe come out. Okay, we publish 4 cases. We can see the regioscope. Every four cases have tried regioscope in the other hospital, but failed. Failed 2 times, 1 time, failed 2 times. And different instrument, regular forceps or reverse kind of forceps, but fail. And may complicate the complication. And just like this case, the fracture, and everyone also have complication. But after we try our technique, we use the flexible endoscope. We use the balloon method, just as I show you, balloon method. Everyone is successful. And they have 2 cases because the foreign body inside caused the tissue granulation, broke glioma, broke the lumen. We had used a laser to bring out to determine the granulation, and therefore we can smoothly remove the foreign body. So sometimes the technique with combination use. Just like this, please. The 7th case. This is a growing extreme premature infant, 4.5 kilogram. Difficult, extreme premature infant because of chronic lung, DPT lung damage, and the long-term intubation and the pressure. So difficult to remove weaning endotracheal tube with mechanical ventilation. Difficult weaning. This is a lumen, tracheal lumen. We can see at the distal lumen malacia, almost complete closed, especially in the left side, total collapse left side. Secretion almost fully and block the lumen. That's why this kind of premature infant, difficult weaning from the airway support and from the pressure and the oxygen support. This is a picture. This side collapse and this collapse at the canal level. With the bronchoscope, we can make actually anatomical diagnosis. That's just kind of dynamic picture help to diagnosis better than the CT or MRI or X-ray. So after the medical diagnosis, you can see this area is broke, is collapsed. So how we do next one? How we do? This is a 3D CT. We can show you at the low trachea and the canana, pre-canana level. The lumen almost disappear. And you can see later view. This canal level is not pattern, it's a severe obstruction. So how we do treatment? The endo cannot win out the pressure, cannot win out the artificial airway. So NIPDV cannot win out. How about tracheostomy? Okay, you see picture like this, the block like this. Tracheostomy only cover up or low trachea, cannot cover the low trachea region, especially around the canal level. So tracheostomy is cannot resolve the blockage and also damage, and also cannot win off the pressure support. So patients still need the ventilator support. Okay, how about surgery? Do the tracheal bronchoplasty. This kind of central airway surgery may need ECMO support. It's too suffer. And also in the left side, left main bronchus, it's difficult to approach because in the rear side, in the back of the heart. So it's difficult to approach. How about stent? What the location? You can see the wide stent. In pediatrics, in small infant, just no commercial available wide stent. And also wide stent is difficult for insertion, and then no appropriate size for small infant. So it's not available. Okay, how about we put a two stent? One big stent in the trachea and then one small diameter in the bronchus. Just two stents. But how about this side? The canal still collapse. This is a problem. So two stents is not okay. So we try the other technique. Okay. We use a long length stent from the one side bronchus to the low trachea, one step. But how about this side? The stem may block the other side, main bronchus. Different diameter of trachea and the bronchus. And how about this area? Mainly broke. Okay. We show how to manage this case with a flexible bronchoscope and ventilation support. Okay, we see the video. How we put on the left coronal stent. We insertion a stent caster to the left main bronchus. And we visual and confirm the stent location. The distal portion going to the main bronchus, and proximal portion just in the proximal trachea, and we inflate the balloon to expand the stent for a couple of seconds, and we deflate the balloon, and we can see the stent in that side, and we remove the balloon caster. And in the stent, in the trachea portion, the stent is not enough, so we put on a big balloon to inflate the trachea portion of the stent. A big balloon to more expand the trachea portion of the stent, because the trachea diameter is bigger than the bronchus. And we deflate the trachea balloon and remove the balloon caster and remove the guide wire, and we check the stent condition. You can see the stent, good structure. As the distal, at the main bronchus. The main bronchus is open, is pattern, diameter is okay. But as a carina, the stent broke the carina of the other main bronchus. So we make a big hole to the other side of the carina. We use a guide wire and insertion a small diameter balloon caster and then inflate to make the hole bigger. To make the hole bigger. And after this management, we finally check the stent condition. You can see at the distal trachea, the stent is okay. The carina, no broke. No lumen broke by the stent, and the left side main bronchus stent is okay. But this patient may have a middle trachea. She may need the other trachea stent put at the middle trachea. But in this case, now the carina movement is okay. So before and after, so before the stent may block other side of the lumen. Left side is okay, but right side carina is blocked by stent. After we make hole over the carina, the other side. Both side carina, both main bronchus lumen is okay. It's pattern. Just like this. The carina stent in the right side, and the other side is made a hole. And then some patient trachea may be still muscle, so we put the other stent to elongate the trachea stent. So this case have two stents, one trachea stent and the other carina stent of right side carina stent. So the benefit of the tracheal frontal stent is if airway like this, the lumen almost total collapse. That's maybe that's reason. But after stent placement, the lumen became much better. So just know the lumen pattern and the breathing is okay. It's not safe. So the stent implantation procedure is less invasive and they can rapidly establish the lumen and improve thermal function. And the rapid win of the support of endotracheal tube or positive pressure ventilation or NIV or oxygen and can diminish and avoid more invasive surgical procedure. So stent is okay. The eighth case, this case have a left coronal stent with a tracheal stent, but the stent may be destruction or damage. So we during the regular follow-up, if stent is damaged, we do the stent casting or stent repair, just like this case. Okay. Side and sometimes the focus. Such case. Another and then you break, repair again. In the different bronchus branch, in different limit, different bronchus in different limit. Sometimes you break postpartum, and then finish, remove bronchus. gradually remove, and we can see the stent is okay. Just no any movement break. Every 3 movement is quite heavy. It's quite heavy. Okay, in the past 20 years, in the 1997 to 2018, we implant 165 stents in different locations, in the upper trachea, middle trachea, or lower trachea, or bilateral bronchus, or the other right coronary stent and left coronary stent, total 165 in 101 patient children. And we remove 78 stents. So this kind of thing is removable and repair can be repaired and can be re-expand because the stent cannot grow, but the movement, baby's movement is growing, but the stent cannot grow. So we really re-expand at a different follow-up time. And in case of less than 5 kg small infant, we also can put the stent at a different site and a different location. All this data we have already published in 2018 and 2019. So all this picture is an interventional bronchoscopy. We use different kind of skill, with source ventilation. Just no any artificial way, no mask, no plating. So conclusion. Anyway, the safety is the most important during the bronchoscopy procedure because all these patients is cardiopulmonary compromise. So safety. How we make the safety? We use the pharyngeal oxygen with nasal closure and abdomen compression. It is very simple and effective and practical NIV support during the bronchoscopy. And it can safely and effectively support the flexible bronchoscopy procedure in different diagnostic or therapeutic intervention in both upper airway or in lower airway, and even in esophagus. That's all. This picture procedure we have already shown you. The stent inside of the 2 different diagnoses. So thank you for your attention. Thank you.